Hello.
Hi.
I may mute you, Sarah, just for a few minutes. Is that okay?
Do what?
I may mute you.
Oh, that's fine. Do you want me to mute myself?
Okay, I'll just mute you for now, and then we'll work from there.
Okay.
Hi, Megan. Let's see. It's nice to meet you, Sarah.
Nice to meet you too.
Glad you made it.
Sorry, I'm about to go pass her off.
Oh, that's okay.
I'll be right back.
Okay. Megan, can you hear me?
Okay.
All right. So Christine and Megan? Hello? All right, so this is being recorded. It's good to have you all here. This is obviously our first class. We do have quite a few weeks of material. And it's kind of up to you guys how you want to structure it, if you want me to kind of breeze through it or if you have specific questions. We probably don't have time for like a full-blown intense lecture, but we can jump into certain things for sure. Do we have any questions about the syllabus so far?
Not yet. I don't.
Okay. So you have your quiz coming up on the 16th. So that's kind of right around the corner. Or it's due the 16th, I believe.
I think it opens, yeah, the 10th.
Okay. You said maybe. Do you have the syllabus?
Or maybe it opens. I don't. Not.
Okay, I'm going to look. Yes, it starts September 10th and ends September 16th. So, okay. Hi, Cooper. And Christine. So the first week was Neurodevelopmental Disorders, which is obviously something that you're going to be working through a lot if you're a school counselor or if you're working with children. Let me kind of just jump into some of the material here. I'm going to see if I can screen share. My internet's wanting to slow down because of all the action that my computer's getting right now. Okay, so I'm having a hard time pulling this up, so it may take a second. But do any of you have any questions about the neurodevelopmental disorders so far? First of all, do you have this book?
Yes.
Okay, I think you do because I've been grading this and everyone's doing fine. So that's a good thing. All right. So in the first, we're just going through the book basically in this class. So the goal that I have for you by the time you leave this semester is just to have a basic working knowledge of most of the disorders that are most common you kind of have an idea of what to look for. But then also the most important thing is knowing like what diagnoses they could possibly be, and know how to look it up and find out which one is correct, if that makes sense. And that's what this is for. There are also some pretty good apps out there that can help you with differential diagnosis. But the quizzes in here are going to be open book. But that being said, you still need to study, because like I said, there's so much material that you're going to at least want to know the ballpark, like have an idea of what it might be so that you can check it. And then if not, look for the others that you think it might be, if that makes sense.
Are they domed?
Yes. Yeah. I'm going to give you like plenty of time, I think, but that's why I say like it's important to study, just so you have an idea, so that you're not like, this is the first time I've ever read this chapter. Let me read it right now in the middle of the quiz, if that makes sense.
Yeah.
And the reason why I want to do it that way is because it is important to know what you're looking for when you're working with clients, so that you know how to best help them, obviously. But also it's important, for insurance purposes. So if you're ever in private practice, you need to be able to diagnose correctly. Or if you're working at an agency, you need to be able to diagnose correctly. And there are tons of really good resources out there to help create treatment plans for specific diagnoses. So obviously, if you can get the correct diagnosis, then you can find some really good treatment options that are, evidence-based and tried and true to help the person you're working with. So let's see if I can actually get in here. And week 1. All right, so there are a lot of disorders. Let's see if I can screen share. I don't know that I can. Oh, yeah, I can. Okay, I can screen share. So I'm going to do that. So I just want to kind of show you what's in D2L, and we'll kind of go through this if you have questions. So neurodevelopmental disorders are obviously disorders that occur in childhood, and they include the autism spectrum disorders, attention deficit disorder, intellectual disorders, which used to be mental retardation, but that's not, we're not calling it that anymore, because the R word can be really offensive and harmful to a lot of people. So those are called intellectual disorders. Specific learning disorders. So for you school people, this will be big. And you probably already have a pretty solid understanding of these, because if you've worked on IEPs and different things like that, then you have dealt with specific learning disabilities. Let's see, I'm gonna move this. Make this bigger. And then tic disorders. So this is like Tourette's syndrome, which I'm sure many of you are at least somewhat aware of. And if you haven't had a chance, I would definitely recommend trying to check out some of these videos, because it kind of really just gives a good idea of what the person experiences when they're experiencing these things. Kind of humanizes it instead of just looking at the criteria. So in order to qualify for a neurodevelopmental disorder, the person must have deficits in reasoning, problem solving, planning, learning, or judgment. And it may result in failure to meet standards for personal independence and social responsibility, and it must occur in childhood. And Rosa's law is what stopped us from using MR as a term. and switched it over to intellectual disability. And that can, of course, be mild, moderate, severe, profound, etc. So there are lots of different types of intellectual disabilities, and they can occur in the realm of, communication disorders, like you said, autism spectrum disorder. And in the DSM-5, there's not a differentiation between Asperger's and autism spectrum disorder. It's just all on the spectrum. So does anyone have any questions just kind of about those so far? No? Okay. All right. I'm not going to go through the videos because I know you can just look at them later. ADHD is a pretty common one. I'm sure a lot of you have seen that have worked in schools. And it's also important to remember that, like, in this class, we'll be talking a lot about different disabilities, but we always want to make sure that we're humanizing the person, because I really like this video because it kind of shows, it just shows how many famous people technically are considered to have a disability, but that they have enormous strengths in so many different areas, if that makes sense. So I'll just breeze through this and see what else. And the tic disorder one is pretty interesting too. So you may want to check that out. And then, all right, week 2, schizophrenia. So let's see. I'm going to share this real quick. So what we're looking at in this chapter is schizophrenia, schizotypal personality disorder, brief psychotic disorder, schizophreniform disorder, and schizoaffective disorder. So schizophrenia is pretty uncommon, but it's characterized by individuals who have, hallucinations or delusions, and do not experience reality in a lot of ways. And then schizotypal personality disorder is characterized by an entire personality that's kind of lends itself to bizarre thinking. They may live in a fantasy world, that kind of thing. Brief psychotic disorder is maybe just having a psychotic episode, but it doesn't last for very long. Schizophreniform disorder is, the individual meets the criteria of schizophrenia, but for a shorter period of time. And often people with schizophreniform disorder get eventually diagnosed with schizophrenia, but the symptoms have to be present for 6 months in order to get that diagnosis. So that's another thing you're going to want to pay attention to, because, for instance, all of these are very similar, but the differences are the time period during which the person experiences the symptoms. So obviously substance or medication-induced psychotic disorder is something that occurs from taking a medication or an illicit drug. Schizoaffective disorder is the symptoms of schizophrenia, but also mixed with a mood disorder like major depressive disorder. Schizophreniform disorder, as we mentioned, is just a shorter period of time, but it is basically schizophrenia. Brief psychotic disorder it could be a day or it could be up to a month of psychotic symptoms. Does anyone have questions about, like, what a psychotic episode is? Let me see if I can flip back over to you.
So they are including the substance-induced and medication-induced schizophreniform and schizophrenia. Because I know a lot of patients, the longer they're using a specific drug, the more issues they have.
Yes. So yeah, you want to rule that. You really want to rule that out. and not, give someone a diagnosis of schizophrenia if it's substance induced. So you would do a substance induced psychotic episode.
Okay.
Yeah.
So it's classified as being something different as
Yes.
substance abuse disorder rather than schizotypal.
Yes. Yeah. And that can be challenging just because some people use drugs because they're self-medicating those hallucinations. So you have to be really careful about that too. But as we know, drugs can cause those hallucinations and delusions as well. So, yeah. Okay. Any other questions?
Yes.
Yeah.
And I'm not sure if this is, I don't know, maybe just my confusion in the chapter. So to be diagnosed with any of them, do you, I guess, start seeing them when they come in and start having the problems and then just continue to see them until you make your diagnosis? Or like, does someone with schizophrenia have to suffer straight out for 6 months before they...
No, you can
Before
still
you
treat
know it.
them. You would just give them either brief psychotic disorder or schizophreniform disorder at first.
And then you just go through and change them throughout the time frame?
Yeah. But you may also find out that they have a history and they've been diagnosed previously and they're just off their meds or something has happened that's, kind of triggered them and got them hospitalized or into treatment somehow.
Okay.
Yeah. So if they they might be able to tell you that they have that diagnosis once they're stabilized on some meds or something.
Okay.
Yeah. Okay.
Are we diagnosing?
Yes. But wait, are you asking in this class or just in your profession or in general?
No. Yeah, when we get our careers, or is a physician diagnosing and then we're just kind of counseling?
No, we are also, well, it depends on what you choose to do. So school counselors will not be diagnosing, but LPCs do.
Oh,
So
I didn't know that.
For instance, I'm in private practice. Currently, I have a very small private practice, but I diagnose every client I see. And the reason I do that is because, because a lot of people have different ideas about diagnosis. Some people don't really believe in diagnosis, things like that. But for reimbursement purposes through insurance companies, you have to have a diagnosis to get treatment for them.
Okay. I didn't know. I thought you had to be an MD to diagnose.
Nope. So LPCs can diagnose. But if you're an LPC in a school, don't diagnose. So even though you can, you will let someone else do that. You'll refer them out. But it's still really helpful if you kind of have an idea of what's going on with that person. So those skills will help you anyway, even if you're not doing the diagnosing in your case notes, which you shouldn't do as a school counselor.
Okay, cool.
Any other questions about that, about diagnosing in general or what we're doing in this class? Okay. So the psychotic disorders, you just want to read and for all of these, you want to look for the duration of the symptoms, how extreme the symptoms are. You're going to want to look for other things that might not fit in that diagnosis, like sometimes someone may have major depressive disorder with psychotic features or with anxious features, something like that. Okay. All right. Let me switch back over to, am I still sharing this with you? Can you see my desktop?
Mm-hmm.
You can? Okay. That's not what I want to be pulling up. That's my presentation. Okay. So let's kind of go over the difference between a delusion and a hallucination. So delusions are beliefs that are not based in reality, and they are not amenable to change in light of conflicting evidence. So there's different types of delusions, like persecutory, referential, grandiose, bizarre. And examples of those are persecutory delusions are like believing that the government is spying on your thoughts. That would be like, and that they know and they're following you and they're chasing you down. And delusions of reference are like believing that a certain radio station plays a certain song to send you a message every day at 1:00. So believing that things are specifically tailored in the environment for them. Grandiose delusions, a belief that he or she has exceptional abilities, wealth, or fame. And automatic delusions, or the false belief that someone is in love with them. And remember that when it's like a psychotic episode, it's always the extreme version of this, because I think, you know, you might see some of these features, grandiose delusions, with personality disorders. And that is a characteristic of like a narcissistic personality disorder, for instance. But maybe someone with bipolar disorder thinks that they buy a ticket to Las Vegas because they have set up an appointment with Jay-Z to drop a record for the weekend or whatever. So, and then bizarre delusions are like really implausible. So the grandiose delusion may sound extreme and is not very believable, but the bizarre delusion is even more extreme. Like organs were removed from my body without a scar, like someone believing that. Some of the other key features of psychotic disorders include hallucinations, disorganized thinking, disorganized or abnormal motor behavior, and catatonic behavior. So hallucinations are seeing, hearing, or perceiving things that are not there. So think of it this way, like the five senses are affected. There could be even like an olfactory experience where someone smells something that's not there. But they're very real to the person who's experiencing a hallucination. So it can be really scary, but it could also be something that's not scary at all. It could be that they just have their bright, vivid colors and it feels good for them. So it's important to remember that not every hallucination is a crisis per se, but it's something we want to be aware of and make sure that everyone's safe, of course. And then disorganized thinking. So we talk a lot, like schizophrenia, one of the symptoms is word salad. So just things not making sense. Things are not in sequential order. It's all over the place and the thread is not connected. So that's what you would look for. And then also grossly disorganized or abnormal motor behavior. So childlike silliness, unpredictable agitation, or catatonic behavior. So catatonic behavior is like the person looks almost frozen. So they don't really respond. They're not following instructions. They may be in a weird pose, and they may, they may not respond to you, or they may be engaged in a lot of motor stimulation and activity, catatonic excitement. You're also going to look for key features of psychotic disorders like negative symptoms, such as diminished emotional expression and avolition. Diminished emotional expression. So lack of eye contact, maybe a lack of emotional expression or facial movements, and avolition. So a decrease in motivated, self-initiated, purposeful activities, or alogia, diminished speech output, and anhedonia, the inability to experience pleasure, and asociality, a lack of interest in social interactions. So to meet the criteria, they have to show some of these symptoms, 2 or more, for at least a month: hallucinations, delusions, disorganized speech, or disorganized or catatonic behavior, and negative symptoms. and it needs to impair their life. For schizophrenia, it needs to last at least 6 months. So, lack of insight is common, which is why it can be challenging to get a solid diagnosis maybe at first. But it's a very rare occurrence. Okay. And then delusional disorder is obviously a little more focused on the delusions. And we covered some of those different delusions, but the presence of one or more delusions has to be present for about a month or longer, but they don't meet the criteria for schizophrenia. So if hallucinations, if present, are not prominent and are related to the delusional theme. Okay. You do want to specify which type of delusion it might be, like erotomanic, manic, grandiose, jealous, persecutory, somatic, mixed type, or unspecified type. But with medication, many people can truly be helped with schizophrenia. Okay, and we kind of covered that a lot of these are about duration. Let's see if there's any that I didn't cover. And definitely take a look at the videos because it really shows some of these. Like, it's kind of hard to understand what word salad truly is until you hear it. So if you have some time, definitely take a look at the video link that I gave you because it will help. And then, of course, so schizoaffective disorder is like schizophrenia, but with major depressive disorder on top. And brief psychotic is less than a month. All right, and then let's go over bipolar disorder. Does everyone know?
Well, we actually discussed the adverse effects of specific medications, like for those that are schizophrenic.
No, probably not. That's a whole other class, and it changes rapidly. You know, in the DSM, it does say like basics about different medications that can be helpful, but yeah, there's so much to cover in this class because we're also going to be looking at the treatment planning aspect. So you're going to try and learn how to actually treat people with certain disorders. Now I can see you while I'm looking at this is better.
So in that situation, is it more for schizophrenia? Are we leaning more as LPCs towards non-medication or symptom management and coping skills, etc.?
So yeah, so my thought is you will likely experience schizophrenic clients in a hospital setting if you're working with them. I have worked with schizophrenic clients in private practice before, though. It is definitely about like encouraging medication compliance, you know, coming up with safety plans in case of hallucinations or delusions that occur. So sometimes it's about challenging the irrational thoughts, but not if they're unmedicated. Don't even try. It's not even safe. You know, I want to just try to stabilize first. And you know, it's setting appropriate routines and coping skills for when people are distressed. So different things related to that. And I'm certainly not an expert in working with schizophrenic patients, but yeah, I mean, a lot of times it is about talking about the actual experience, the hallucinations, the delusions, to demystify it. Because, you know, the more you can kind of help separate that from their reality, the easier it is for them to go back to that as a coping skill and remember. So it's a lot about that, but it's also about like processing what life is like, because sometimes it's a very tough mental illness. I mean, we just described the fact that catatonia occurs. That is uncontrollable. They can't, it's the inability to move sometimes. So what's it like living with that and struggling with that? That can be challenging. So sometimes it's about processing that as well and coming up with realistic goals and plans for someone's life within that. Whereas, so schizophrenia is on the more severe side, but like schizophreniform disorder, if it doesn't continue and stay schizophrenia, could go away. Same with like a brief psychotic disorder. Someone could have a psychotic episode and never have another one again. So sometimes it's about managing expectations in the actual diagnosis. And sometimes, it's about just moving past it and processing it and working through it. And as far as let's talk a little bit about treatment planning for neurodevelopmental disorders. Except my screen is now frozen. So, obviously, each of these, and that's why it's hard to even get into treatment planning for all of these in such a short period of time like we have. But like ADHD, that's something that's very common that you'll work with in a variety of settings. So in schools, but also in community centers as well.
I have a question about that.
Mm-hmm.
Okay, so this is the most updated version, right? This book we have?
Yes.
Okay, does it mention anything about ACEs with the ADHD, or is that still like so new that it's not in the book yet?
ACEs meaning, is that the assessment?
Adverse childhood something.
Yeah.
It's
adverse childhood experiences.
That's it. Yep, that's it.
Yeah. That's not in the DSM.
Okay.
But I know it's becoming a larger part of many people's practice. So I think it's a really good thing to look at because, when you think about ADHD, wow, you have to really ask yourself, is this ADHD or is this ODD, oppositional defiant disorder?
Right.
Or is this maybe just sort of a normal reaction to a traumatic environment that the child is in?
Right, which would be part of ACEs.
And so knowing the history of the family can be really helpful in that way.
Okay.
And
so
go ahead.
Okay, so for like what we're doing though, we don't really need to think of ACEs or any of that stuff. It's really still lumped together on ADHD still, right?
Well, ACEs can be used for anyone. I mean,
right.
So it's not really necessarily connected to ADHD.
Right. Well, that's what they're trying to teach. Well, I mean, I like it a whole lot, but that's what they're really having us look at now as school psych counselors is it ADHD or is the symptoms we're seeing here actually ACEs? That's why I was asking about it.
Sure. And so the way you would want to think about that diagnostically is differential diagnosis. So you would want to look at, is this maybe actually PTSD? Post-traumatic stress disorder, or oppositional defiant disorder, or just, some kids come with not a lot of structure in the home, so that can affect just the things that they've learned or internalized can be different.
Right.
And, the important thing to remember is diagnosis is important because it can kind of lead you in the right direction. But at the end of the day, if you have strategies that are helping the kid, that's what matters most. So it's kind of like it guides you. It can point you toward things to help them. But especially as a school counselor, you don't have to diagnose. But it's good information to have because you can get, a variety of ways to treat. if you have an idea of kind of what we're looking at.
Okay. All right.
Yeah, like with autism spectrum disorders, you know, it's a lot about changing the environment and providing a teacher accommodations and training parents at home to provide things that are helpful to stimulate the child, with like stimming and different, you know, things that are helpful and soothing to them. But it's also about training the children with, gosh, I can't remember what those are called, but like the social stories. So you can use social stories to help them identify feelings, to communicate feelings, because communication is such a big challenge with autism spectrum kids. And then, of course, intellectual disorders, it depends on the intellectual disorder. Specific learning disorder, it depends on the specific learning disorder. And in a private practice setting, or a community setting, you wouldn't really be working with the specific learning disorders as much, because you're not really there. You're there to treat the social emotional aspects of it. Like, so if it's affecting their self-esteem, or if you need to advocate with the school counselor or the special education coordinator to make sure that they're getting accommodations, something like that. But, you know, you're not going to be like working with them on a math related specific learning disorder. Yeah. So any questions about those? And a lot of these too are such intense specializations that that's what's tough about this class, because I feel like you could become an autism spectrum disorder specialist. You know, you could be an ABA therapist. You could become a specialist in working with tic disorders. But you know, most of you are going to work with probably ADHD, possibly, you know, some autism spectrum disorder, even if you're not the primary person who's working with that person. You're probably going to experience all of these at least at some point in your career. Okay, so let's hop into bipolar. Does everyone have an idea of what bipolar disorder is? Yeah, most people have heard of it. It's one of the most commonly diagnosed disorders, but there are some things we want to specify. So you can have severe mania, hypomania, normal mood, depression, severe depression. So bipolar 1 disorder means that you have, you know, mixed moods of major depressive disorder, so really down, depressed times, and then times where you're having a manic episode. And you may have, like, someone with bipolar disorder may have psychotic symptoms, but they don't have to. Bipolar 2 disorder means that they have major depressive disorder, and then they have manic episodes. So the difference between a hypomanic episode. So the difference between a manic episode and a hypomanic episode is that a hypomanic episode is less severe. So a manic episode means that you are, you know, you could be up all night. Let me see if I can. Yeah. So here is the criteria for a manic episode. So you are abnormally and persistently in an elevated, expansive, or irritable mood, and it has to last at least a week. And you need 3 or 4, if the mood is only irritable, of the following symptoms: inflated self-esteem or grandiosity, decreased need for sleep, pressured speech or more talkative than usual, flight of ideas or racing thoughts, distractibility, psychomotor agitation or increase in goal-directed activity, and hedonistic interests. So people who are in a manic episode are spending money like crazy that they don't have. They may be using substances. They may be having lots of unsafe sex or just engaging in like lots of reckless types of behavior that can be really damaging to their personal life, or even their professional life. The hypomanic episode, so this is, it could it necessitates hospitalization to prevent harm to self or others. It can have psychotic features that are not due to the substance use. So like during those grandiose episodes of thinking that they're amazing and doing wonderful things with their life and spending all this money, they could get into a psychotic space where they believe maybe they're God, or they've received a message from God, and that they're really going to these extreme lengths to express that or something. And a hypomanic episode is less intense. It's a shorter length of time. The impairment is not as severe, and it may be viewed by the individual as pathological, but and others may be troubled by the behavior, but it may not impact their life in a super negative way. Maybe they're not spending recklessly, but maybe they're just staying up late to work on a project for multiple days in a row, and they feel they're like the Energizer bunny, supercharged, but it's less severe. A lot of times people like their hypomanic episodes or their manic episodes because they feel great. They feel euphoric. They're goal directed. They're able to accomplish more than they would normally. The problem is, of course, either when they're crashing because they're dealing with the consequences of what happened during the manic episode, or they're crashing because they then go into a depressive episode. And of course, that's, when the depression hits, loss of interest in activities, depressed mood, that lasts at least 2 weeks. I'm also going to just share cyclothymia. So cyclothymia is, it's just a less severe version of both. But it can last for at least 2 years. So numerous periods with hypomanic symptoms that this says doesn't meet the criteria for hypomanic, but that means manic. So they may have hypomanic times present at least half the time and not without for longer than 2 months. And then the criteria for major depressive has never been met. So cyclothymia means that they could have those shifts in mood, but they're not as extreme over a long period of time. So that's kind of why we look at all of these on this continuum, if that makes sense. And when we're diagnosing, again, just looking at length of time and severity can kind of help. And then there's unspecified bipolar and related disorders. They don't meet the criteria for any specific disorder, bipolar disorder, but it looks like it and seems like it, kind of. Okay. Any questions about this? And it's got some good examples in here about like what mania might look like at a school. And some people may miss bipolar 2. That's frequently missed because, again, they're not in full-blown mania, so they don't have the psychotic features. They may be only sleeping a few hours a night, but they are sleeping. They can usually function at work and school. They just seem to have all this energy for a couple, days. Okay. And then there's rapid cycling specifier. So this can be applied to bipolar 1 or 2. And that means that you can have 4 or more mood episodes within 12 months. So it can appear in any combination, but must be demarcated by a period of full remission or switch to an episode of the opposite polarity. Okay. And so they're talking a little more in this PowerPoint about the changes in the DSM-5, and it's still really challenging to diagnose children with bipolar disorder. And it's, I mean, can you guys think of why that might be?
Hormones, puberty.
Yep. So many changes occurring in such a short period of time, right?
Yeah.
But also, yeah, I mean, what could be seen as extreme moods at certain times, it's hard to know what's normal and what's not during certain periods of growth and development. A good way to try to help make this differentiation is looking at sleep patterns. So if they can go for multiple days without sleep and seem unfazed, and then they have the mood swings, then you're probably looking at the possibility of bipolar 1 or bipolar 2. You may want, so if you're looking at this PowerPoint in D12, a really good thing that's helpful is if you look at kind of these differential diagnosis, so differential consideration in these charts, because it can kind of help you decide, like, well, is this bipolar 2 or is it major depressive disorder? Or is it cyclothymic? Or is it substance induced? You always want to ask, is it substance induced? And then, ADHD could be, someone might think it's bipolar disorder, but really it's just, there are a lot of different things in ADHD that can present themselves similarly. Shifting mood. Yeah. Okay. Any other questions about this one? Okay. Yeah. What will be most helpful to you moving forward? Because like right now I'm kind of just breezing through the chapters. Would you like more specifics about the differences between them or more treatment considerations? I guess we didn't talk about treatment considerations for bipolar, did we? I'll talk about that. So for bipolar disorder, well, it obviously depends on the type, but medication is an important piece of this as well. So encouraging compliance with medication, and also working through comorbid diagnosis. So again, this is one of those that people often will self-medicate with different substances to try to manage the symptoms on their own before they get a good diagnosis. So with all of these, psychoeducation can be really good to help them understand what they're trying to manage. And then good self-care, of course, is really important. Also attempting to manage the fallout sometimes from a manic episode, because life can be really challenging and unpredictable for people who experience these symptoms. But it's also, again, like very manageable if people are medicated well and they have good care. Any questions about that? No? Okay. Well, these are the big chapters that we're covering in the first few weeks, and we'll have a quiz on those. I know it seems like a lot, but don't be too scared. Mainly, I just want you to be able to identify each one for the most part. Is there anything specific that you all need?
I have just a, not totally on this question, but a you question. Are you in the office here at Midwestern on your?
I am, yes. So
Okay.
I'm there typically Thursdays are the day I'm there the longest, from about 10 to 5.
Okay.
I'm there Fridays from, well, I'm usually there early in the morning until about 2, but my technical office hours are from 11 to 2. But I'm also available by phone. So I put my cell phone on the syllabus.
I saw. I wasn't sure since you live in the Metroplex.
Yeah. But yes, I am at MSU 2 days a week. So
Okay. Awesome.
if you need anything, but also I'm available to Skype during my office hours too. So for all of you who may be elsewhere or you just can't make it to the office, we can do that too, or talk on the phone.
Okay. Thank you.
All right. Well, yeah, that's kind of how these classes are going to go. But I'm also open to suggestions. So if there are things that you specifically want me to address in a certain way, I'm kind of like breeze through each chunk and just answer questions that you have. I really recommend, though, that you look at the videos and in the module, like everything that's in the module, because it really helps kind of, this is a dense book. And if you're just reading through it, it can be hard to digest. So I would recommend just like kind of watching the videos, breaking it down piece by piece to try to just get a general understanding of each of these disorders. Because like I said, you can specialize in one of these, and we're covering a whole book. So as long as you kind of have the basics down and an understanding of what each one is and the symptoms that present and the time frames, you should be pretty much good to go. But it's going to be helpful to look at those videos because they really show what it's like to have the mental disorder. So that can be helpful too. All right. And also, if you have any suggestions, like email me, or questions, email me, and I will try to incorporate those into the optional classes as well. Okay? But other than that, that's all I have for you. So is everyone okay with us ending the meeting for now?
Yep.
All right. Take care and let me know if you need anything. Have a great night.
Thank you.
Thank you. You too.
All right. Bye.
Bye.